is the right and left hip with both the iliac fossa and the pubic rami covered. This is called as a squared pelvis at the same level, and this line, this Shenton's line, is broken when there is a fracture of the femur neck. This is, we have the acetabulum here. If there is a like a central dislocation of the femur neck, this acetabulum is broken, and the femur neck is gone into the pelvis. This is how you can diagnose. This is what we call as the lesser trochanter here. This is the greater trochanter. Coming to the types of fractures you have around the femoral neck and the head, we have the subcapital. That is, at the starting of the neck, you have a fracture that is called as subcapital, and the middle of the neck it's called as mid cervical, and you have a basis cervical that is at the ending of the neck, and then you have a trochanteric fracture, that is the greater trochanter being separated, and then you have an intertrochanteric fracture, and you have a subtrochanteric fracture, that is the at the metaphysis, the diaphysis and the metaphysis are broken. There is one more fracture known as the reverse trochanteric fracture. This is the most unstable form, and usually it needs to be operated. However, most of the fractures nowadays, they don't go for conservative management, because what can happen if there is a neck of fracture? What can happen to the head? Can someone tell me? Yeah. Is it audible?
Yes, sir, it's
Ganesh?
audible.
Yeah, yeah. What happens when there is a fracture neck of femur? What happens to the head? What is the complication you normally expect? Do you know, or you can put it in the chat box if you don't know. I will go forward. Okay, that's okay. What happens is, as a child grows, the most of the nutrition to this head, no, in a child comes from the foveal arteries. Foveal arteries are the arteries coming from the acetabulum. But as we grow, this foveal arteries degenerate. Only few arteries will be there, and most of the blood supply in adults come through the neck and in older people. If there is a neck fracture, the blood supply to the head is compromised, hence it goes to the avascular necrosis. That is, the whole head goes at necrosis. It basically rots. So, in an elderly, if you have a neck of femur fracture and the head is not that healthy, what you do is you remove this head and put a prosthetic head. That can be either a ceramic head or a metal head. Could someone tell me how do you differentiate between extracapsular and intracapsular fractures in a femur neck, if you know? Or you can type if you know what is the main differences. Could somebody tell me fast? Okay. Okay. Yeah. What happens is, if there is in intracapsular fracture, basically the capsule is attached like this. Okay. In intracapsular fractures, no, the shortening is very less because the capsule will be holding it tight. So the length compared to the normal side will be almost same. But if it is an extracapsular means either an intertrochanteric fracture or a subtrochanteric fracture, the shortening is more because there are pulling muscles which are pulling this whole thing up. So the shortening is more. And this kind of neck of femur fractures are seen more common in females because the neck is very weak. And this intertrochanteric fracture, they are high velocity injuries. That is, there is more force required to break. Hence, they are seen in males. And there is more degree of external rotation in intertrochanteric fractures. That is, the limb will be formed sideways because there is nothing to hold the rotation. Whereas in an intracapsular fracture, this capsule is holding this fragment tight. So hence the external rotation is less. This is an X-ray of central dislocation, fracture dislocation of the head. You can see what has happened here is the acetabulum is here. The head has gone into the pelvis. This is a central fracture dislocation. There is fracture. This is an intertrochanteric fracture extending from the GT to the LT. And this is another X-ray showing fracture neck of femur. You can see this limb has gone in for external rotation, because normally in a normal X-ray the lesser trochanter is only very small, but as you see, when there is a fracture of the neck, the lesser trochanter becomes more prominent. That is why when you are taking an X-ray for fractured neck of femur, you should be having you should try to extend rotate the limb, even though if it is painful for the patient. Uh, what are these screws called as? Don't read this. This is a cancel screw, right? Do you know what this screw is called as? The patient had a neck of femur fracture probably, and they are treated with this screw. What are those screws called as? If you know, you can answer, or you can type, or you can say you don't know. We can move forward. I want you to talk. We'll finish it fast.
Don't know.
Do you know?
No, sir.
No much information about it, sir.
Okay, fine, no problem. These are called as cancellous screws. These are called as lag screws. Why they are called as lag screws is because here we have a neck of femur fracture. We have put 3 screws here. What they have done is this. Basically, this has threads here. So what happens is, and there is a head here. When you tighten this screw, this is holding the head, and as you tighten, this is acting as a compression force for the fracture. So the fracture is compressed. So these are called as lag cancellous screws. They lag and pull the other fragment towards itself and cause a compression in the fracture side. This is another fracture of comminuted fracture. Comminuted fracture because there are many pieces here. You can see a head, the neck, and there is one GT behind it, and there is one diaphyseal fragment. This is a comminuted fracture of the neck, and probably treated with the maybe you can treat it with a dynamic hip screw. What they have done here is a static hip screw. In a static hip screw, you have a plate that is giving the pressure, and this screw is put to the head holding the other fragment. Usually the lesser trochanter, you can leave it like that, or you can put a wire to it. Yeah, that is it about it. Could someone tell me what is the normal neck shaft angle in a patient, in any human beings or in Asians? What is the neck angle between neck and shaft? It is given in your BD Chaurasya book. Does anyone know? Around, if you can get. Okay. The normal neck shaft angle is about 125 to 135 degrees. So when you are doing this correction, no, they have to see that the angle comes about the same. That is, you usually go with a 130-degree angle while fixing the neck of femur fracture. This is another fracture that is showing intratrochanter fracture. These are common devices which are used. The gold standard for treating a neck of femur or a fracture, intratrochanter fracture, is the dynamic hip screw. Why it's called dynamic? Because this is holding the neck fragment, and there is a spring-like action here. So as you tighten this and this screw, this acts as a compression. So basically, when the patient stands, this body weight is acting as a compression for the fracture fragment. This is a static hip screw because there is no movement mechanism. This acts by the principle of holding the force. This acts on the principle of body weight. And this we have an intramedullary nailing with interlocking. That is, if you have a diaphyseal fracture, they put a rod into the nail. It's called as an IM nail, intramedullary nail. Okay, they put that rod and they lock it down and up, so that there is no rotation taking place. This is intramedullary nailing, and this is intramedullary nailing with interlocking. Interlocking because you have put 2 screws so that the fragment does not rotate. These are load sharing and load bearing devices. That is, they help with the bone to share the weight, or they itself bear the weight. This nail is basically a load sharing device because it shares with the bone. This thing, here new bone has to form, and these plates are load bearing devices because they transfer the weight from this fragment to this fragment, and there is no continuation in the bone. However, now we have locking compression plates and dynamic compression plates which work on load sharing also. This is another fracture of the diaphysis where they have done a plating, and they have put the plate to the anterior or the lateral aspect of the limb. Yeah, coming to the knee joint, this is the normal anatomy of the knee joint. What we have to remember is, in a knee joint, we can take an AP or a lateral view, and this is the fibula here. This is the tibia. This is called as the tibial plateau. These are the femoral condyles, and this is forming the knee. There is one more important structure. This is patella. Could someone tell me what type of bone patella is? Do you know?
Sesamoid bone, sir.
Yeah, very nice. Why is it called a sesamoid bone?
Because it is between the muscles. It is inserted
Yeah,
in the muscle ligament.
yeah, correct. It forms anything that grows or forms inside a muscle or a soft tissue is known as sesamoid bone. Could you, Govindan, could you tell me some other sesamoid bone which you normally, which is commonly found other than patella? Okay, flabella is one bone, and there are
No
multiple.
idea, sir.
Yeah, okay. The flabella. One of the thing is flabella, which is found in the hand. Okay. This is the lateral view of the X-ray. Here you can see the joint space. This is the patella. Which muscle it is implanted in? The patella. Could somebody else tell me other than Govindan? Which muscle is the patella attached or?
Quadriceps femoris.
Okay, quadriceps. Yeah, that is right. Quadriceps. The quadriceps comes from above and attaches to the patella posterior, and later it forms a sheath or a tendon, and it continues down into the tibial tuberosity as a patella tendon. Okay, this is the lateral view, and here what you can see is there is a direct force to the patella, and patella has got broken down into two pieces. And what they have done here is they have put a wire, that is a K wire or something, and they have tied it in a figure of 8. So what happens is every time there is a distraction force, when you put a rod and put it in the figure, this acts as a compression for the patella. This principle is known as tension band wiring principle. You can use a wire, you can use a rope, you can use devices, you can use elastic coils to tie the patella. So you tie it in a figure of 8. Such kind of things can be done in for calcaneum also, or you can do it for olecranon fractures, where you use the muscle which is distracting as a compressive force. This is another transverse fracture of patella which you see, and we can most probably they will go with the tension band wiring. Earlier they used to do a practice called as patelectomy, but what happens is once you remove the patella, the action of the quadriceps is gone. Why quadriceps is required? It is required for the extension of your leg, or walking, or doing a straight leg raise when you're sleeping. So if you remove the patella, the action of the quadriceps is gone, because this is acting as a lever, so that a minimum force is okay when you're lifting the lower limb. So the patelectomy is not followed now. So they go with the tension band wiring unless it is so communicated. This is another view of the. This is basically a mortise view. Okay, this is not an AP view. AP view doesn't come like this. This is a mortise view because you can see this ankle syndesmosis. That is the ankle mortise. So you have the lower end of the fibula, the tibia, and the talus here. And what is this part called as in an ankle? Malleoli.
Malleolus, sir.
Malleolus.
Correct. It's called as a malleoli. Okay.
Medial malleolus.
Medial malleolus, which is the this is a little high, I know, but it's good to know things. Okay, so what is the common ligament that is injured when you have an ankle sprain? Commonly, patient come with a lateral side pain, telling that there is swelling on the lateral aspect of the ankle. One common ligament gets torn or injured commonly. Do you know? Or you can guess some ligament which is there.
Transverse ligament.
No. Could somebody else? You can try. You can try. Can you name some ligaments that are there around the ankle? Yeah. Okay. We have spring ligament, deltoid ligament. Okay, such as the anterior talofibular ligament is the most common ligament that is getting injured. It goes like something like it comes like this. Okay, this is most commonly injured. Patient come with that, and usually you can give a 4-week rest, and that is okay. This is usually when there is a fracture of the ankle, no, there is associated injury because if being is going like this, I mean the foot is going like this, they can fracture here and they can fracture here. So you have to look on both the sides for a fracture. Here we can see there is a medial malleolar fracture and there is a lower end fibula also fracture. Uh, yeah, they have put a screw here, and this is also like a lag screw they have put, and here they have constructed syndesmosis. Syndesmosis is nothing but where the joints, I mean the bone, the ligaments, all are working as a complex mechanism. That is syndesmosis. So what they have done is they have put a screw from the fibula to the tibia, so that this fragment is held, and one more they have put from medial malleoli to the tibia. This is called as bimalleolar fracture. Okay, this is can be treated in such a way, or you can put a plate to this side, which is acting as a compression force. This is a common ankle dislocation. You can this unless there is a fracture, you can reduce it by using a axial traction. This is another fracture. You don't have to remember the name. This is called as Stodler's fracture. That's okay. This you can see why it's called a Stodler's fracture is uh, there is no fracture in when you see AP. How can you know this is a young guy? Because here there is still the physis is not joined, and this is still a young or a child that has come to you, and there is no fracture when you see on AP view. But when you see on lateral view, there is a clear cut oblique fracture that is running like this. Okay, that is why it's called as toddler's fracture. This is called as boot top fracture. Why? Because boot here both diaphyseal break of the tibia and the fibula. The boot usually comes like this, and the boot is hard. So when you have a trauma, the bone breaks above the boot. Okay. What if there is a fibula fracture? Can you leave it like that without treating it? Yes or no? Just have a guesswork. Suppose you have a fibula fracture, where a patient has come to you. Can you leave it like that? It's like, okay, chalo, nothing will happen. And tibia is intact. Can you leave it like that?
No.
Right?
Yes, sir.
Yes. When can you leave it like that? Like, is there any criteria for leaving it like that, or you can leave all fibula fractures for it like that? Okay. But see, if the common people, what surgeons follow is if it is 8 centimeter from the lateral malleolus, no, we leave it, we treat it because it's very important for the ankle joint functioning and most of the muscle attachments and holding. This is a functioning part of the fibula. But if it's way above and the tibia is intact, you can leave it like that because it will unite on its own. Okay. And it's not a matter. And usually, if you need a bone graft, you can take it from the mid segment of fibula or iliac crest. These are like even take the graft from there. Also, when you have osteomyelitis is nothing but infection of the bone and periosteum. Suppose the tibia is fully rotten like this, and you have tried out everything, putting a bone cement, putting an antibiotic cement, putting extra fixate, nothing is working. You can do a fibula tibia transplant. That is, you cut the fibula and you implant it inside the tibia like this, so that the bone grows around the fibula. This is known as fibula tibia transfer. Just for your knowledge. Now, this is another X-ray of foot. That is dorsoplanar view. You can see the phalanges that are there, and you can see here two sesamoid bones are also there. These are the metatarsal. Then you have medial, lateral, and the intermediate cuneiform from the medial to lateral side. Then you have the cuboid. Okay, and so navicular and talus and all that. Not that clear. This is common fractures that we see. This is another lateral view where you can see calcaneum, talus, and the lower end of fibula is also visible, and the same bones which we saw in the AP view. This is a calcaneum fracture. What happens is, what type of bone is calcaneum? Is it a cortical or a cancellous bone? Just can you guess? Always femur, tibia, all these are hard bones. They have a cortex. That's why they are called as cortical bones. Whereas cancellous bones, no, they are like calcaneum. They are soft bones. Okay? They basically are like what you can say, a sponge dipped in cement. So they are that soft. And when you have fracture of this, they don't usually break. They just get compressed into a smaller size. Okay, that that is what. And what you can do in most of the calcaneal fractures, unless it's comminuted and broken like that, you can leave it like that with a slab, because this will, the person has to adapt. He will have a long term pain, but you cannot do much about a comminuted calcaneal fracture, because it's like a sponge which has got compressed into a ball. You can't do anything much about it. And one more important thing when you decide on the calcaneum is that this is Bowler's angle. Okay, what is the Bowler's angle? Bowler's angle is a line drawn like this. Okay, and this angle is known as Bowler's angle. This angle lets you decide whether there is any compressive fracture, because otherwise you can see that the calcaneum has just decreased in its size. The normal is about 20 to 40 degrees, what they say. This angle is very important so that you can decide on that. Here we have tarsal and navicular fracture. Nothing much to do about it. This is another fracture. This is a Jones fracture, or it's called as a dancer fracture. That is the fracture of the metatarsal at the neck or the base. What happens is this is commonly seen in patients taking steroids because it is normally under stress, the fifth metatarsal. Patients with long-term steroids, this bone becomes weak, and without any trivial trauma, without any trauma itself, patient will come to you telling that there is pain and I have got a fracture, and you will be surprised because there is no trauma. This is called as Jones fracture. However, what we call as fragility fracture. Some of the common diseases we discussed before ending for today. Here we have gout. Gout is the deposition of uric acid in the joint. So what happens is the uric acid gets collected in the joint, and the joint goes into arthritis. What is arthritis? Arthritis is the inflammation of the joint. Here you can see there is many calcification which is happening because of irritated soft tissue, and there are gouty changes here. Okay, this is how a X-ray of gout, and basically what happens is the uric acid eats away your joint or the bone. Okay, that is commonly seen, and it looks like a dirty joint, and you know that there is some arthritis, and then you have to biochemically working out for uric acid level, rheumatic arthritis, or something which you're suspecting. These are all one. And one small table on arthritis. First of all, when a patient with joint pain or an arthritis or joint inflammation comes to you, you have to categorize it. That is monoarthritis. There is only one single joint is involved, or there is polyarthritis. So you can narrow down the diagnosis. This is in your life future when you practice also you can follow it. And if you have monoarthritis, it could be because of trauma, something that might have hit. There could be bleeding inside the joint, and he can get pain because of that. It is because of joint infection. There is either external piercing to the joint, or and what you call as osteomyelitic infection that is spread to the joint, and then you have gout, and then you have rheumatoid changes. Okay, then other thing is polyarthritis, that is inflammatory joint diseases, that is rheumatoid, that is more than one joint is involved, and like that. And then you have ankylosing spondylitis, which are rheumatic variants, Ritter syndrome, psoriatic arthritis. Psoriasis is a common skin disorder. The same thing happens in the joint, then it is known as psoriatic arthritis. Then you have degenerative. Degenerative is wear and tear, where there is primary osteoarthritis, that is with age, and secondary arthritis because of some cause. And then we have metabolic, like gout, amyloidosis, and all that. Gout comes, as you can see, both in mono and polyarthritis, because gout can only involve a single joint. Usually, commonly it involves your great toe at the beginning, and then you can progress to others. Okay, you have a patient with some joint disease, and how do you categorize it into inflammatory, degenerative? Coming to symmetry, the inflammatory joint is usually symmetric. As you can see, rheumatoid arthritis involves your DIP and PIP in a symmetric fashion. That is, both hands should be involved. But a degenerative change, suppose osteoarthritis patient, that he is telling you, or he or she is telling you that she has a joint pain, she will always tell you that I have right knee joint pain more than left, because knee joint pains are common in Indian, because our culture is more towards sitting down and doing stuff sitting. may it be grinding or kitchen work or anything. But what over the time we have developed Italian kitchens, we are standing and we are westernizing our culture. So basically we are standing and doing. So most of the Indian women are going in for osteoarthritis. And even in metabolic, it will be asymmetric because it can involve any joint. Usually inflammatory conditions are polyarticular, but metabolic and degenerative can be poly or mono. Then these are not important. I would like to put a note on bone density. In degenerative changes, what the bone tries to do is it will try to protect the remaining part of it. So what happens is bone density increases in degenerative conditions. And also about osteophytes. There is a reflex extra bone that is being formed. You can see it as osteophytes that are present in osteoarthritis. I will be showing you the pictures later on. We have examples for inflammatory is rheumatic arthritis. Rheumatic arthritis usually presents with increased pain during the morning and freeness later on, more so in the hand, and they can present you with Raynaud phenomenon. That is, and there is a cold, their fingertips become white. That is not. And degenerative such as osteoarthritis and metabolic such as gout, where the uric acid levels are off the table, and you have to bring down the uric acid level. And also you can give, in all the cases, you can give them painkillers and treat them like that. Now we have what the physiology, what is happening there. There could be physical forces, that is a trauma or degeneration, or chemical forces, that is the metabolic. And what happens is the cartilage which is there in the joint alters to function. What happens is when there is trauma, there is usually the chondrocytes take the nutrients from the synovial fluid, but then blood vessels start to form. There will be cracks in that. There will be multiple fragments of it, and the flakes of it, that is parts of it, will start chipping off because it is starting to calcify or it is starting to get degenerated. What happens is then the joint space decreases. Then what happens? Articular deformity might be there, subchondral cysts may be there, there can be sclerosis, there is excessive synovial hypertrophy, and there can be subluxation because the joint gives off. This is a picture beautifully explaining the degenerative joint disease. It could be an osteoarthritis, where you can see this thing, this fragment, that is tibial plateau and the fibular, the femur contacts are hitching over each other. What happens is extra bone formation and has led to a sharp thing like this. This is osteophyte formation. And what has happened is these chondrocytes or the bone bodies have got chipped off. What we do is usually we put an arthroscopy inside and we give a wash that will prevent in a short term. But in long term, we give them changes such as we prevent them from sitting down. We give them coordinating sulfate or glucosamine so that some amount of cartilage formation normalizes, and we tell them to do exercise on using a chair and or standing. This is ideal X-ray where you can see it has more become white because extra bone formation. You can see there is formation of osteophytes, and also there is some amount of subluxation because the line of the femur and tibia are not in line, which you normally see. And this white thing what you see is nothing but subchondral sclerosis, that is below the cartilage, that is sclerosis taking place, and there is some amount of subluxation and deformity also. Now, this can happen in the knee joint, which is shown here, or it can happen in the lumbar spine also. Commonly, lumbar spine, you can see spondylosis or spondylolisthesis that is happening. That is in spondylosis. Also, there can be extra bone formation. The intravertebral disc compression can be there, and also there can be pressing on the nerve root, which can function as nerve symptoms. These are joint diseases where there is a degenerative disease which is taking place in the distal interphalangeal joint is known as Hubbard nodes, and what in the proximal it is known as Burchard nodes. It's not that important unless you go into diagnosis. Commonly, metacarpals don't go for osteoarthritis changes, but sometimes very rarely first metacarpal, that is of the thumb, that can go for osteoarthritis. This is seen by decreased joint space and increased white extra bone formation and pain. And patient can present to you like that. This is another X-ray where scaphoid fracture he has. How can you diagnose if a patient has scaphoid fracture or not? This is one small secret I'll be sharing with you. If a patient comes to you with a fracture and you are not seeing anything, how can you suspect scaphoid fracture? Where is the anatomical landmark of scaphoid? Could anyone tell me? Yeah. Do you know? Okay. Do you know where is anatomical snuff box?
Yes, sir.
The radial side. The
Yeah.
dorsal.
Anatomical snuff box. Yeah, correct. Exactly. Anatomical snuff box is a place where the scaphoid is. Exactly. So if the patient comes to you with a fracture and you don't see anything on an X-ray, you can just press him on the anatomical snuff box. And if he complains of tenderness, that is pain, you can suspect a scaphoid fracture. You can put a slab for now, and you can ask him to come back after a week, so that you can do a repeat X-ray and you can not miss the scaphoid fracture. Just like the femur neck fracture, the scaphoid also can go in for necrosis because uh, yeah. Just like the femur, no? Scaphoid is somewhat boat shaped, and instead of the blood supply coming from here, the blood supply comes like this. That is from the distal end. So if there is a fracture here, this portion can go in for avascular necrosis. What happens is this is an important bone in the joint, that is the wrist joint. So if this gets avascular necrosis, the whole joint goes in for arthritis. Arthritis is nothing but inflammation. This is a step by step how an arthritis develops. This you can see there is minimal early changes are there. Some amount of joint space has decreased. No much of things you can see. Then later you see that there is a severe loss of the joint space with new osteophytes formation and sclerosis also. At last, you can see that this has gone for a total varus, that is, the leg has gone medially, and you can see there is literally no joint space that is visible, and fully sclerosed, that is whitish osteophytes that are there, and reactive osteophyte formation is also there. So you can see how severe is your osteoarthritis patient which has come to you. This is another X-ray of the knee, which is showing you the recombinant. Uh, that is on the there is loss on the recumbent position, but when you see an AP view, it is not that clear. Is what they are telling. What another thing which you can observe in joint osteoarthritis or degenerative condition is the presence of loose bodies. These loose bodies, first thing is they cause pain, and second thing is they prevent your flexion and extension. And so, if you have a patient who is coming you with degenerative joint disease, you are diagnosing with osteoarthritis, but his flexion and extension are not full range of motion, you can suspect a loose body, and you can send him to an orthopedician to get it cleaned or washed. This is another X-ray where you can see how you can differentiate an inflammatory arthritis and a degenerative. A degenerative arthritis basically is not uniform, but an inflammation is totally involvement, so it is a uniform joint phase loss. This is has to be like differentiated clinically also because he will in inflammatory condition he will have conditions such as associated osteomyelitis or he may have fever and so and so, and there will be local rise of temperature which can also be there in degenerative condition but not that progressive, and degenerative condition is usually having a very long history than compared to an inflammatory arthritis. He will tell you that it is progressing. This is another disease, rheumatoid arthritis, that is commonly seen where multiple joints are involved, usually bilateral, and increased complaints in the morning, and family history may be there, and such things are common in rheumatic arthritis. Yeah, that is okay for today. I think you have Viva, so I will be stopping today here, and we'll continue next when we get time. You can ask me questions if you have. Guys, any questions? Any doubts?
No, sir.
Sir, we approach you in the next class with the questions we have. We'll
Yeah,
go
yeah.
through.
You can just yeah, you can do that. And
Next, what we are going to cover, please let us know so that we can prepare ourselves, like study something at least.
yeah, yeah. Because anatomy, I thought you had finished in last class because of your exams. I didn't want to
Yes, sir,
study
that's
anything
not
else.
an issue. Like we can revise things so that we can understand better. Rest the class was
Yeah,
good,
yeah,
no
no
issue.
problem. Yeah, okay. I will let Ganesh know regarding the topics of next. When is your Viva finishing?
23rd, sir.
Okay, okay. We are going slowly. I'll let you know the topics before so that you can read the theory part of it and come and you will understand better. Okay, all the best for Viva then. Thank you. It was nice teaching.
Thank you, sir.
I'll just
Thank you, sir.
I'll just share this. I'll just share my. I'm just sharing my phone number and my email ID. This is my phone number. You can WhatsApp me any doubts anytime. This is 8762920055. Okay, this is my number. And my email ID is srinivas@gmail.com. Okay, you can mail me also. It would be better if you WhatsApp cherkadi@gmail.com. Okay, you can note it down if you want. Any doubts in this topic, anything you want to clarify, you can just text me or you can mail me. Okay, and it was
Thank you, sir.
lovely teaching you. Thank you.
Thank you, sir.
Thank you, sir.
Yeah,
Thank you, sir.
Thank you, sir.
thank you. Your exams, do well. Yeah.